Let's jump straight into this. Welcome to today's Explainer, where we're tackling an advanced postgraduate review of spontaneous intracerebral hemorrhage, or ICH. Today, it's all about mastering how to map clinical signs directly to a bleeding brain. We are basically acting as anatomical detectives here, reading the exact physical signs a patient presents with to pinpoint precisely where a rupture just happened. And to understand why this matters right this second, just look at the global burden. Stroke accounts for a staggering 61.2% of all neurological deaths worldwide. When a vessel bursts in the brain, the clock starts ticking instantly. You don't always have the luxury of waiting around for a scanner to tell you what's wrong, right? Your clinical exam is your absolute first, and sometimes your most vital diagnostic tool. So here's our roadmap for this explainer. We'll quickly cover the neurologic method, contrast the main drivers of ICH, and take a top-down tour of the brain, from the deep structures all the way to the lobes, before wrapping up with clinical evolution. Section 1. The neurologic method. This is all about figuring out the where before the what. This idea brilliantly illustrates our core framework. As the source material puts it, deciding where the lesion is accomplishes the task of limiting the possible etiologies to a manageable finite number. By first pinpointing the anatomy based on the symptoms, we automatically narrow down our list of suspects. If we know where the bleeding is, we get a massive head start in knowing why it's happening, and, ultimately, how to save the patient. Section 2. Hypertension versus CAA. Let's break down the two main drivers of spontaneous ICH. On one side of the ring, we've got chronic hypertension. This relentless pressure attacks tiny, deep-penetrating arteries. We're talking microscopic, just 30 to 100 micrometers, in areas like the basal ganglia, thalamus, pons, and cerebellum. On the flip side, we have cerebral amyloid angiopathy, or CAA. This typically targets older patients, but instead of those deep vessels, it degrades cortical or lobar vessels closer to the surface of the brain. Pathologically, CAA leaves behind these amyloid deposits in the artery walls that literally light up with Congo red staining. So you've got two very different diseases attacking two completely different vascular neighborhoods. Moving on to Section 3, deep brain bleeds. Let's start with the most frequent victims of a hypertensive hemorrhage, the putamen and the thalamus. When a hypertensive hematoma hits the left putamen, it creates a massive bright white mass on a non-contrast CT. And because of where it sits, this bleed directly threatens the adjacent internal capsule. Think of the internal capsule as this massive superhighway of motor fibers traveling down to the rest of the body. Because that superhighway gets compressed, the damage shows up clinically as the classic putaminal syndrome. The primary sentinel sign here is contralateral hemiparesis. You'll also see unilateral facial sagging that develops over 5 to 30 minutes, along with slurred speech. But here is your major localizing clue. The patient's eyes will actually deviate away from the hemiparesis. Basically, they are looking toward the lesion itself. Now, if we shift our focus just slightly over to the thalamus, the clinical picture completely changes. A thalamic hemorrhage still hits deep brain tissue, sure, but it causes profound sensory deficits and some highly complex ocular disturbances. This happens because the bleeding tends to extend inferiorly straight into the upper midbrain. So how do you tell a thalamic bleed apart from a putamenal bleed right at the bedside? Well, like the putamen, a thalamic bleed can cause contralateral hemiplegia by pressing on the internal capsule, but it comes with a prominent sensory deficit across all modalities. The real differentiator, though, is that thalamic bleeds uniquely disrupt ocular motility. They force the eyes downward and inward. It literally looks like the patient is staring at their own nose. You'll also catch unequal pupils that just don't react to light, and sometimes a skew deviation where one eye sits lower and more medial than the other. Section 4, brainstem and cerebellum. We're now descending into the posterior fossa, where the stakes instantly become life-threatening. We absolutely have to talk about the pontine hemorrhage. This is a catastrophic brainstem bleed. Because the pons houses the critical pathways for consciousness and motor control, a hemorrhage here evolves over mere minutes. It is a true clinical nightmare. The classic diagnostic triad here is something you need to recognize instantly. We're talking rapid onset of deep coma, quadriplegia with prominent decerebrate rigidity, and pinpoint, literally 1 millimeter, pupils that remarkably still react to light. If you see that deep coma, locked-in motor response, and those pinpoint pupils, there's no question. You are looking at a pontine hemorrhage. Which brings us to a highly time-sensitive scenario. While trials like STITCH and STITCH 2 showed limited benefit for early surgery and a lot of deep bleeds, and the newer ENRICH trial has really reshaped our view on minimally invasive evacuation for lobar clots, there is still one area where open surgical evacuation remains an absolute non-negotiable necessity: the cerebellum. A cerebellar crisis usually kicks off with an occipital headache, repeated vomiting, and severe gait ataxia. The patient might feel terribly dizzy or just can't walk a straight line. But as that hematoma expands inside such a tight space, it brutally compresses the fourth ventricle and the brainstem. Stupor and coma follow rapidly. Recognizing that initial ataxia and headache is absolutely critical, because once hydrocephalus or brainstem compression kicks in, immediate suboccipital decompression and evacuation is required. An EVD alone simply won't be enough to save them.
Section 5. Lobar hemorrhage syndromes. Let's travel back up to the cerebral cortex to examine the bleeds that are frequently driven by CAA.
Because these bleeds are cortical, we can map the patient's focal deficit perfectly to the specific lobe involved. Occipital involvement gives you hemianopsia, left temporal causes aphasia and confusion, a parietal bleed brings hemisensory loss, and a frontal bleed usually presents with arm weakness. It's just brilliant, direct anatomical mapping in action.
Section 6. Clinical evolution. Now, we need to address the absolute most dangerous phase of all this: the immediate aftermath of the rupture. You have to remember, the hematoma is not a single static event that just happens and stops. Symptoms usually worsen over the first 30 to 90 minutes. In fact, up to 1/3 of all patients experience significant hematoma expansion within the first 24 hours, even without any underlying coagulopathy. The clot actively grows. It progressively worsens those focal deficits and shoots intracranial pressure through the roof. This is exactly why critical care management has to be super aggressive. We're talking immediate blood pressure control and the urgent reversal of any anticoagulation using targeted agents like PCC, idaruzumab, or andexanet alpha. You have to halt that expansion.
So I'll leave you with this final provocative thought. You know the bleed is likely to expand. You know that minutes literally equal brain tissue. In the race against an expanding hematoma, how will your mastery of clinical localization save a patient's life before the CT scanner even warms up? By spotting a specific eye deviation, or recognizing those pinpoint pupils, or catching early ataxia, you instantly become the anatomical detective. You narrow down the cause, you anticipate the complications, and you accelerate life-saving treatment. Thanks for joining me on this explainer, and keep looking for the where so you can perfectly treat the what.